Welcome everyone to this new edition of the Paper of the Month. I'm Aurélie Najm, and it's my pleasure to also introduce you to Polona, Žigon from the EULAR-EMEUNET Journal Club team.
Hi, today we are going to discuss the manuscript selected by our audience in the Paper of the Month online poll on social media. This work has been recently published in Arthritis and Rheumatology, and it is our big pleasure today to introduce the first author of the paper, Dr. Stefano Alivernini from the Università Cattolica from Rome, Italy.
Hi, Stefano, and welcome.
Hi, everyone, and thank you for being selected for as a paper of the month. And I thank you very much, and I'm very happy to be with you to discuss the results of our study.
That's amazing. We're delighted to have you as well. So the manuscript is entitled "Synovial Tissue-Derived Characteristics are included in a nonogram for the prediction of treatment response in naive rheumatoid arthritis." So thank you for accepting to share your results with us. We are now going to ask you a few questions about the manuscript.
First, we are interested. Could you please tell us what was your objective of your study?
Yes, sure. The main aims of our study was first to assess the diagnostic value of performing a semi-quantitative scoring system for grading the synovitis degree on synovial tissue samples obtained from minimally invasive US-guided biopsies in a large biosample dataset of array patients compared to patients with other forms of inflammatory and non-inflammatory joint diseases, and to identify possible pre-treatment synovial biomarkers associated with disease characteristics or predictive of treatment response in naive to treatment array.
Thank you. It's very clear. I think it's quite impressive as well that you had such a large database and cohort and biocollection. So can you tell us a bit more about your cohort?
Yes, the cohort that was used for this study is derived from our synovial tissue biopsy unit that is called SYNGEM at the Division of Rheumatology of the Fondazione Policlinico Universitario Agostino Gemelli here in Rome, in which actually US-guided minimally invasive synovial tissue biopsy are performed within a routine care or research settings in patients with different chronic inflammatory joint diseases as rheumatoid arthritis, psoriatic arthritis, or forms of undifferentiated arthritis. And in this context and in this workflow for each patient, the assessment of the synovitis degree is performed by trained pathologists using a H&E-based method, using and applying the Kranz synovitis score, which was implemented with other parameters such as the presence or absence of lymphocytes, plasma cells, granulocytes, or mucoid degeneration. And in this study, we included a large cohort of 1,064 patients who underwent synovial tissue biopsies of the knee, and patients were followed for the rheumatoid arthritis subgroup for at least 6 months to record the remission achievement rate after treatment and to answer to our research question.
Huge work indeed. So you were able to analyze synovial tissue histological features across disease stage, essentially in rheumatoid arthritis. So can you summarize your main findings?
Yes, as you correctly said, the main target of this study were naive to treatment array to answer our first question. So we perform an initial comparative analysis of synovitis degree across disease phases in array and PSA, for example, that were actually stratified based on being naive to treatment or non-responder to conventional DMARDs, in that case methotrexate used as a first-line conventional DMARDs, or at the time of sustained clinical and ultrasound-based remission achievement. And this comparative analysis showed that first of all, the Kranz synovitis score is contingent with disease phase in array, with a strong direct correlation with disease activity score as the DAS28. And actually, to focus better our analysis on naive to treatment, we analyzed deeply the subgroup of patients with naive to treatment array. So we included 240 naive to treatment array. And we found that the naive to treatment array who were referred as a first rheumatological assessment and so performed the synovial tissue biopsy after 12 months from the symptoms onset had a significantly higher Kranz score compared to patients who were referred within the first 3 months. So they were as a very early rheumatoid arthritis patient. So we step forward analyzing different clinical parameters as the autoantibody positivity, as is already known to be associated with different synovial tissue features in array. And so stratifying patients based on the ACPA and or rheumatoid factor seropositivity, we found that in naive to treatment array, patients who were seropositive for ACPA or rheumatoid factor showed at the beginning, at the first rheumatological assessment, a significantly higher Kranz score for in global, and even assessing the 3 sub-items composing the composite score, and so the synovial hyperplasia, the stromal density, and the inflammatory infiltrates. And interestingly, the titer, the plasma titers of ACPA and rheumatoid factor in naive to treatment array were found to be directly correlated with the Kranz synovitis score found at the synovial tissue biopsy. So this analysis confirmed that the timing of first medical evaluation and the autoimmune features, as well as the baseline disease burden, significantly impact the synovial tissue composition of the inflammation degree in naive to treatment array.
Thank you. That's for this very comprehensive description of the results. I think it's very interesting, especially as you were able to subdivide these into different early array groups. So that was really nice. And is there any specific biomarker that you would say is really able to predict which patients are going to respond to methotrexate? Were you able to analyze this in your work?
Yes, so this is the same question that arises after this first comparative analysis. So each naive to treatment array was then treated with a first-line conventional DMARDs that in this case was methotrexate for all at the maximum tolerated dose of nearly 20 milligrams per week, based on the recommendation for the management of array. And each patient was followed in an outpatient clinical setting every 3 months to assess the achievement of DAS remission with the first endpoint of 6 months follow-up, respectively. And so we analyzed the factor that could be differentially distributed among patients who achieved DAS remission compared to patients who did not achieve this clinical outcome. And we found that, of course, being a very early disease at the first medical evaluation, or not having a high disease activity, were factors associated with a better response to first-line methotrexate treatment. But interestingly, incorporating and including the assessment of the synovial tissue inflammation at the time of first rheumatological evaluation, we found that a lower Kranz score and even a less presence of plasma cells within the tissue were factors associated with a DAS remission achievement at 6 months. And interestingly, this analysis was supported and developed even in a logistic regression multivariate assessment, confirming that these factors are independently associated with the remission achievement at 6 months, and they have a sort of multiplicative effect between them if they are combined together. So we have an odds ratio of DAS remission of around 3 if we consider each parameters based on the disease activity or patient characteristics. If we consider in an individual way, and we increase up to 12 the odds ratio of DAS remission if we consider the 3 parameters combined together.
Wow, you really gained a lot of information. And could you describe us what features were finally included in the nomogram and what were the nomogram's performances?
Yes, of course. Once we identified these independent factors associated with the remission achievement at 6 months of treatment, we decided to include those parameters within nomogram, which can weight each parameter according to a point reference to achieve a total score to identify the rate and the percentage of remission achievement that could be up to nearly 90% if a patient fulfilled the 3 combined features at the time of first medical evaluation. And in that sense, the calibration of the prediction model that we developed was performed, and we actually tested the power of our nomogram, because the nomogram was subjected to actually 1,000 bootstrap resamples for internal validation to assess its predictive accuracy.
Yeah, I think this is one of the biggest strengths of your study, to be able to have such numbers, so you can really use a robust statistical approach. So that's really interesting. I think it's the first time that synovial tissue parameters are integrated in a nomogram. So how do you think this could impact the clinical practice?
Yes, actually, I hope that these results open new, new ways in the development of future research, because this is indeed the first attempt for the management of array to integrate within a nomogram together clinical and tissue-derived characteristics that could be applied at the disease onset of array patients. But this kind of approach is widely used in cancer field, for example. So we could learn from other subspecialty how to implement in the future our decisional algorithm, even in the clinical practice, when we will manage in a more comprehensive way array patient in our clinical setting.
Yes, this is a really novel study, very interesting. Can you please tell us now what are the next steps and direction of your future work? Do you plan to maybe expand this work to other diseases or other outcomes?
Yes, actually, as you saw, the Najm biopsy unit, as is described even in the paper, includes different cohorts of patient types. So not only limited in array, but even array not responding to conventional DMARD. So, for example, eligible for biologic beginning, and even other forms of chronic joint inflammation diseases like psoriatic arthritis or spondyloarthritis. And to date, actually, our study is in line with even other attempts and other reports done from multiple research groups in Europe, which support the assessment of synovial tissue composition as possible additional tool within novel personalized protocols for RA. So based on these, actually, we plan to extend, first of all, our approach in different disease phases of RA course, and even to other forms of chronic joint inflammation, for example, as psoriatic arthritis, where the field is still not so developed in terms of personalized approach. And so our aim is in the future, of course, to develop possible novel algorithm, even with multiple disease outcome that could be even more stringent, because our target in the management of such diseases has to be better and better over time. And so everything has to be done to improve at our best the personalized medicine in our clinical practice for such category of patients.
Yeah, absolutely. As you know, I'm probably biased because this is a topic that's very close to my heart, so I could not agree more with you. But I think you know, you made this very crystal clear as well for everyone else. So thank you for that, for sharing with us the outcome and perspective arising for this very exciting work. It was a pleasure to be with you today, to have you with us, and I really hope that our audience will enjoy watching this interview as much as we enjoyed recording it. Thank you.
Thank you to you. Thank you.
Thank you.